I look forward to the discussion we will have. So what Monica, Gapa, and myself will talk about is about Z-scores. We will go systematically through a few cases of lung functions, and we will give you a few multiple choice questions to answer. So I start with this concept of Z-scores. And I start with a poll. Which of these results, these values of FEV1 is abnormal or pathological? A 90% predicted, an 80% predicted, a 50% predicted, a 75% predicted, and we have added also a it depends for either people who do not know it or who have other ideas. So I'll let you vote. And very nicely, half of the people have said it depends. And I hope it's not because they did not know, but because they know that really it depends. So the 80% is very often used. It's okish to use it. Pulmonologists have used it for decades, but modern pulmonologists should not use it anymore. Why? Because it really depends on which population you're looking at. And the new reference values that you basically should now use if you perform spirometry, they will give you mainly standard deviation values for your patients or Z-scores for a group population instead of percent predicted, because this abrogates the problem of the variability that you have between populations. And I try to show you why this is so. If we have two groups of children who perform spirometry, a group of 6-year-olds and a group of 14-year-olds, healthy children, no lung disease, well, you will have a different distribution of FEV1 values. Amongst the 6-year-old children, some will be not very good at performing the lung function tests. They will have very low FEV1 values, percent predicted for the age, because they're just technically not so good at doing, and other ones will have higher values. While if you look at the 14-year-old children, they will be more kind of standardized. They will be all in the mean, more able to do it the same way, and therefore the shape of the curve will be much narrower, and you will have more narrow normal values. And if you look, for instance, a value of 60% of FEV1 in a 6-year-old child, this is probably still somewhere in the normal range, but in a 14-year-old, this is out of the normal range. And that's why it's better to use the standard deviations or the Z-scores. And what are these standard deviations? When you have a normal distribution of anything, or here of lung function values, then within one standard deviation, so from -1 standard deviation to +1 standard deviation, you have 68%, so about 2/3 of the values. And 95% of the values, they will be between -2 standard deviation and +2 standard deviation in this range. And so if we use what we like to use in medicine is kind of the 95% confidence interval, or the interval from the 5th percentile to the 95th percentile as what we call normal, then we can use a -1.64 standard deviation to 1.64 standard deviation as what we call normal. And this is then completely independent of the variability. So this will apply as well as for a 6-year-old boy as for a 14-year-old boy. I hope this concept is clear. And so now we work ourselves systematically through a few cases. So when you look at complete lung function, so the big lung function with the spirometry and the body plethysmography. This is what I suggest you to do. First, you look at what patient, really if you have the correct patient, and so the static volumes, then you look at the resistance loop, then the flow volume curve, and then if the patient has done any other tests. So we start with this case number 1, where we have a 10-year-old boy with an allergic asthma. He's treated with inhaled steroids and long-acting beta-2 agonists, but clinically he's not well controlled. He has symptoms, he has wheeze, he's not very well. He gives also an asthma control test of 18 out of 27 points. And if now you look at his lung function, that's something like this that you will get as a printout. Few figures, a lot of numbers. And we start first of all at looking at the patient, really at these numbers here at the top, what's written. So it's in German, but you might still understand it. So you will look at the 4 important things that influence your lung function values. So the age of the child, 10 years, if it's a boy or a girl, the ethnicity, here it's Caucasian, white, and the height of the patient. Then you look also at the date where the maneuver has been done. That was last November in this case. And then you look at what has been done. I'll show you. So there are something that I've done first with a Z-score, and then a nach means after. And so in this case here, this has been after inhalation of salbutamol. And these were the things that have been done after salbutamol, and these are the things that have been done before salbutamol. And as a code, color code that you might have also on your body plethysmogram, the blue things are the ones that have been done before salbutamol, the red ones after. Here also the blue before and the red one after. So I start by looking at the static volumes. These are the numbers here. You see TLC, IgG, and so on. And this will be here somewhere in this curve. And if you look which curve you have to look at, it's this curve here. It's the FRC curve. The blue one is really what the patient has done. And the black one is what the computer, how the computer has drawn the line in this blue line, the best fitting line. What you see here is on this axis, the movements of the thorax, the effort of breathing, and on the y-axis here, you see the pressure at the mouth. And this is the story of the balloon that I told yesterday. If you have a large balloon and you do some breathing efforts, we will not have much pressure different in this balloon. But if you have a small balloon and you do the same effort, you will have huge changes of pressure in this small balloon. So the bigger the changes here, the steeper the curve, the smaller the balloon is. If the curve is flat like this, then you have a large balloon. And if we look now at the numbers, what is measured here is the FRC in the plethysmogram, which is the same than the ITGV, the intrathoracic gas volume. It's the volume in your lungs when you breathe quietly here, when you breathe against the closed shutter. We look at the values. It should be 1.87 liters. It was, or it has been measured 2.49 liters, so this is much increased. It's 133% of what it should be, and this is a Z-score that's elevated. It's much more than 1.6, it's 3.4, so it's markedly elevated. If we look at the curve after the salbutamol inhalation, it gets a little bit steeper, and the values are now have decreased. Here it was before salbutamol 2.5 liters and after salbutamol 2.0 liters. So now the value is 100% of what it should be, or the reference predicted values. It's 0.6 Z-scores. It's completely normal. It's within the ranges of minus 1.6 to 1.6, and it's 80% of the first value. So you have a hyperinflation after inhalation with salbutamol, the volume gets better. If we look at the other numbers here of the static volumina, so we have here with the shutter measured the FRC, the intrathoracic gas volume. And then the next what the patient does is the expiration. Here in our setting, in some other settings, is first the inspiration. The expiratory volume And here you see this is a little bit decreased. This 60% of what it should be. It's a negative, highly negative Z score, so it's too small. And because of this, your residual volume, which is calculated by subtracting the expiratory reserve volume from the functional residual capacity from the intrathoracic gas volume, is too high. So this is the trapped air basically that you have in your lungs. So the patient is hyperinflated. He cannot breathe out so much air. The expiratory volume is too small. And that's why the residual volume is markedly elevated with a Z score of 4.8. What the patient then does from this point here is to do a complete vital capacity maneuver, inspiratory, which of course will be a little bit reduced because he has not been able to expire completely his air, so he cannot breathe in so much air. And this is also a reduced Z score. And finally, you come to the total lung capacity at the top, which will be, because the patient is hyperinflated, a little normal or a little bit elevated. Important to see here, the vital capacity is a little bit reduced. It's not that the patient now has a restrictive problem, but he has a functionally diminished vital capacity because of his high residual volume, and we call this a pseudo restriction. Not a real restriction, but a pseudo restriction. All in all, we can say that the patient has a hyperinflation. He has elevated volumes here. And one good volume you can always look at also is the residual volume in percentage of the total lung capacity. The next thing we will look at is the resistance loop. So these are these values here. And what we look at here is this curve now. So this is the specific resistance loop, the one that is measured in your patient here. This is the curve that the loop that the patient has done, and the black line is how the computer has drawn the line. Here it is the effective resistance loop that we look at. So it's kind of the middle of this open loop here. You could also take the total one, but we prefer the effective specific resistance because it's a more stable value. And you see already from the steepness of the curve that it's more flat here than afterwards after the salbutamol. What you measure here is again the work of breathing, the efforts that the patient makes to open and close his lung, to move his lungs. But now the shutter is open and you measure the flow that goes through the pneumotrachograph. And if you have opened airways, large airways, well, there will be a lot of air going through for the same effort and the curve will be steep. If you have increased resistance, small airway, the airways which are narrow, then the curve would be flat. And you see it's flat, and when you give salbutamol, it opens. If you look then at the value, the resistance is markedly increased, 700% of the normal value, of the predicted value, which corresponds to 22 standard deviation. It's very, very high. And after salbutamol inhalation, the Z score is still very elevated, but much better. You have a 2/3 decrease of these initial values. So you can say it's an increased resistance. And the next thing you will look at is the flow volume curve. So what you have done with your forced spirometry maneuver. Again, first look at the curve. The blue one is what you have done first. The red one is what you have done after the salbutamol inhalation. Here in gray, you have actually what would be the normal values for this age, for this patient. And the black line in the middle is the median values for this group. You see that the curve has been done well. You have a sharp increase of the flow. You have a good peak. You have a straight line. It's concave, so it's significantly of an obstruction in the peripheral airways and a good inspiratory loop here. And it's much better after inhalation with salbutamol, but still not normal. This is reflected by the values also. If you look central airways, what has been calculated, you cannot read the FEV1 here from this graph. This would be the time, the flow time curves that you would, the volume time curve that you would need to depict here. But the FEV1 that's been calculated is decreased. It's a marker of your large airways. it's markedly decreased, and the MEF 25 to 75 is even decreased more because you have a strong peripheral obstruction, which is not completely reversible after salbutamol inhalation. If at the same patient you look at the inflammation of his airways, you can measure the fraction of exhaled nitric oxide. Here also, you first look at the graph. The graph here, you have 3 attempts that have been done. You wait to measure for, or the machine measures you when you have a kind of a plateau to average this plateau curve. You see that the maneuver has been done acceptably. It's 3 efforts, ATS, ERS criteria have been respected. You have here the expiratory flow, which should be 50 milliliters per second, which is a little bit lower, but that's acceptable. The coefficient of variation of the 3 tests is less than 10%, so you can use it. And if you look at the values here, you have 67 ppb, which on average, once is 64, 77, 69, so 67 is a good average. It should be less than 20 at this age, so it's markedly elevated. This is compatible with your allergic asthma that is not well controlled. We go on to the case 2. This is a 14-year-old girl. She has a muscle disease, myotonic dystrophy. She still can walk, but with help, and she has some problems of getting her secretions out because she cannot cough so well. She has a cough assist to help her with this. You look again first at the values, if it's the right patient, at what date the test has been done. So it is a girl, 14-year-old, weiblich means girl. The ethnia here is black. So this is important to look at if you live in France, in Switzerland, Germany, or wherever, where you have a specific or an ethnia that is more represented, then your lung function technician might forget to put the correct thing here, and then you have completely wrong values. So this is important to check, and the height of the patient. If your patient is not able to walk anymore, like in a neuromuscular disease, well, then it's difficult to use the height because you cannot really have a standing height. What you can then use as surrogate marker is to use the arm span. Because you see that on this picture of Leonardo da Vinci, it is quite similar to the height of the patient, the arm span. And you can use this as a surrogate marker. If the patient has contractions, then you need, you cannot measure from here to here because maybe the patient cannot move his arms very much broad. So you need to measure from here to here, and here to here, and then here to here, here to here, and here to here to add all these measurements to get your arm span. So again, here we look at the static volumes first. These are the numbers at the top here, and this curve, we have no bronchodilation here with salbutamol, so it's just one curve, the blue one. And we first look here at this small curve that has been done for the FRC measurement, the FRC curve. And you see this is a very small curve. I'm not sure if you really can use it. It has been difficult for the girl to do it because she has a muscle problem, and here you have to breathe again this shutter, so where the mouth is closed, you have to do this exercise. This is technically difficult to do, probably not done very well. So you have to really be aware, maybe look how the measurement has been done. Not sure if you really can use this curve, but if you use it, you will have a value that's very much reduced with a low z-score. If you want really to see, okay, is this small volumes that the child really can mobilize, then the vital capacity is a good thing that you can look at. The vital capacity in this child is markedly decreased. It's 34% of the predicted, so that's a standard deviation score, z-score of -7. And you can always compare if the inspiratory maneuver gives you about around the same values that the expiratory forced maneuver. It should be about the same. Normative values are a little bit different here, but you see 1 liter, 1.1 liter, and which is quite similar. So you can really say the child has a restriction. If you look at the specific resistance curve here, then you have a very steep curve with normal values here. The specific resistance of 112% predictive, which is a normal z-score. So the resistance is not increased. This is not an obstructive problem. And if you finally look at the flow volume curve in this child, you see already, okay, the curve is very small. It should be here inside, but it's very small because the volume that has been mobilized is small. Therefore, all the values will be also quite small. Unfortunately, here the computer could not calculate the FEV1, the FEV1 divided by FVC, probably because the effort has not been so repetitive. And what's interesting, if you look at these points here, the curve, is that actually the values of your MEF25, for instance, are quite normal, but they should be much reduced. Why is this? This is a technical problem that you will often see because the curve is stopped too early. You can not see only this in restrictive lung disease, in any lung disease or any test that has been done. The child should have expired until here. And when you measure the MEF25, you take here the point, basically here in the middle of your FVC, you will have the MEF50, and when you have 1/4 left, the MEF25. But in fact, if the child would have expired completely, the middle would be here, and the MEF25 would be about here. So the maximal expiratory flow with 25% of your FVC is down here, and which be much lower than the value that has been given here. So now I pass to Monica for the third case, and I'll be back for the questions. Monica, I don't hear you. Can you put your microphone on?
I can do that, and I need
okay.
Back.
Good.
Okay, so I take over now and start all over again. This is the case of a 12-year-old girl who was too much talking today, who was sent for uncontrolled allergic asthma. She reports dyspnea and shortness of breath during exercise despite high doses of inhaled corticosteroids and LABA step 3 to 4 treatment. And you've seen such lung function protocols before. And again, I apologize because this is a German lung function or German wording here in this lung function protocol, but the important things, the parameters are international really. So first we start at looking at the static lung volumes like you've done for the previous cases. Here you've got the graphic display of the TGV FRC measurement, body plethysmography, baseline, post-exercise, post-bronchodilator. And from the steepness of the curve, you see already that nothing happens. Same is true if you here look at the values. It's 2.02 liters prior to exercise. It's 1.81 liters after exercise. And after bronchodilation, there's no absolute value, but there's still not really a change. And then we add some more detail. So normal static lung volumes, normal vital capacity, the slow maneuver done during body plethysmography. There's just one thing I would like to highlight, which is residual volume, which is always displayed with the body plethysmographic measurement of lung volume. And if you remember, expiratory reserve volume is the volume which is expired during the total lung capacity maneuver. Expiration to residual volume, it's the volume between FRC, so tidal breathing, resting, and expiratory lung volume, and then down to residual volume. And here you have a value of 0.36, which is equivalent to 42% predicted RZ score of -3.99. In comparison to all the other volumes, this is really suspiciously low, and maybe an indication here that although the curves here look quite regular and reproducible, that this the breathing maneuver was not quite good. And as the residual volume is calculated from FRC minus ERV, you will get a falsely elevated residual volume, an impression of hyperinflation and trap gas, although this might not be the case. So always look at expiratory reserve volume, whether this is in line with the other measurements or suspect. It's a difficult maneuver for many children. Yeah, and this is illustrated here. Residual volume is an active maneuver, and if this is not good, then your residual volume, it's small, your residual volume will be overestimated. Okay, and then we have from the plethysmography the specific resistance, which is 1.25 during the baseline measurement, which is as elevated, mildly elevated for this child at 12 years of age. After exercise, there is not really any change, 1.3, and again, no change after bronchodilation, as you can see here from the steepness of the resistance loop. So no sign of bronchial hyperreactivity with this non-specific challenge test. And the same is actually true if you look at the forced expiratory flow volume loop and spirometry. We've got a technically acceptable maneuver with a distinct, sharp rise to peak flow, and then a very reproducible expiratory flow volume curve down to residual volume, which does not change from baseline to post-exercise to post-bronchodilation. And if you look at the numbers, if you look at the numbers, you have a normal vital capacity, you have still normal FEV1, you have mildly reduced forced expiratory flows, but still within the normal range. But you have a sharp rise to peak flow, but if you look more closely, the peak flow is lower than expected. It's supposed to be 5 liters per second, and it comes out at 3.78 liters per second, which is equivalent to a Z-score of minus 1.8 or 75% predicted. Now this raises the suspicion that there is something different going on, but asthma suspected fixed central airway obstruction, no hyperreactivity, no reversibility, and this girl underwent bronchoscopy to look for differential diagnosis of difficult asthma, and indeed she had tracheal and left main bronchostenosis on this flexible bronchoscopy. So this was case number 3. And then I have 2 cases of cystic fibrosis. If you remember, it was the multiple breath washout looking for changes in small airways we have been discussing yesterday. Now, this is a young male patient with cystic fibrosis. He, at this time, is already a young adult at age 19. He had cystic fibrosis with both gastrointestinal involvement and pulmonary involvement, but in terms of the lung, he only had intermittent culture, positive culture for Staph aureus, and has been doing really well despite being pancreatic insufficient for all of his life. Here is his lung function, body plethysmography with static lung volumes and capacities here, and spirometry with the values here. And it's technically very good. You see he has routine in doing lung function, very good shutter maneuvers, reproducible resistance loops, no change following bronchodilation, spirometry, it's his personal distinct curve pattern, which he always has with this sort of bow here, but a normal peak flow other than here, other than the previous case, a good rise to peak flow, a smooth forced expiratory curve. So technically everything is perfect. And volumes are normal or even supranormal in this young adult with cystic fibrosis, vital capacity 131%, 118%, so positive Z scores. Normal spirometry, no evidence of obstruction on spirometry, normal lung volumes, no hyperinflation. For many years, we have been doing multiple breath washout measurements routinely during the outpatient visits for cystic fibrosis patients. And in fact, he had mildly elevated lung clearance index, as you would expect at that age, just above normal, 8.5, but stable for years. And then at the age of 16, the LCI slowly started to increase, went up to values of around 11 up to 12, which is clearly abnormal. So we discussed what was going on. And actually, he was very reluctant to increase his treatment without any definite, more definite diagnosis. He felt, well, he wasn't doing his treatment as regularly as you want him to. Physiotherapy was not really his thing. So for further workup, he underwent CT, and we found central bronchiectasis, evidence of structural lung disease with these this completely normal conventional lung function. And because he wanted to know what was going on, whether there was anything but Staph aureus to explain this change in lung clearance index and the bronchiectasis on the CT, he underwent bronchoscopy and really had this very typical CF appearance of lots of secretions, purulent secretions, yeah, well, that was a basis to discuss treatment, home treatment, physiotherapy, inhalation with hypertonic saline. Yeah, LCI in this patient indicating towards more severe disease than conventional lung function would suggest. And this is the case of a much younger boy with cystic fibrosis. Again, and I don't think we go through this in much detail. Here you've got body plethysmography again, here you've got spirometry, both of which are technically acceptable. If you look at the static lung volumes, you have normal or high normal total lung capacity, high normal functional residual capacity, but again, this is in line with the spirometric volumes. Forced vital capacity of 119%, predicted 1.57 Z scores, no change after bronchodilation, really no, here in this young patient, even the forced expiratory flows are entirely normal. Here you see a graphic display of the Z scores in the green range, so no evidence of changes here whatsoever. He also underwent multiple breath washout regularly and had completely normal results most of the time, with values of 7.1, which is clearly within the normal range. You see a very smooth decline of the nitrogen concentration. So everything was fine. But then all of a sudden his LCI increased to values that are clearly abnormal, here around 10. And from one of the next routine sputum cultures, Pseudomonas was grown. This was the first Pseudomonas colonization infection in this boy. He was treated, and following treatment, the lung clearance index came back to normal. So here, again, evidence that the multiple breath washout technique gives you additional important information in patients with cystic fibrosis. Okay, and now we come to some more general issues here. Again, case 6 is a boy of 13 years of age who was referred by a pediatrician who had done spirometry for a suspected asthma, but got low lung volumes, and he was referred with suspected restrictive lung disease. The 13-year-old boy was quite tall with 172 centimeters standing height and slim, 53 kilos. He had a spirometry which looks technically acceptable with a sharp rise, peak flow, and a smooth and reproducible decline of the forced expiratory curve. The vital capacity, so I apologize, we have been talking about Z-score so much, and here is the percent predicted. It's an old example. So the values for the forced vital capacity and FEV1 are both below the normal limit for this boy, with normal flows, no evidence of obstruction, but suspicion of restrictive changes. And the same is true for body plethysmographic measurements of lung volumes. Here, intrathoracic gas volume, FRC, is below normal with 1.94 liters, calculated as 71% predicted. Now, he is asymptomatic, doesn't complain of shortness of breath or anything. So how can we explain that? If you look at this boy, he is very tall and probably had a pubertal growth spurt. His height is at the 95th percentile, equivalent to a Z-score of plus 1.62. However, his torso, his thorax, is rather small compared to the length of his leg. And there are some normative values for a ratio sitting height divided by standing height. And if you plot his torso length against a standing length, including the legs, then you find him below the 50th percentile, or Z-score of 0, while his standing height is in the upper range. So the lung volume is probably, lung volume measured is probably normal for his chest size, and there's no evidence for restrictive changes and restrictive lung disease in this boy. So the message is, look at the children before you state or judge a lung function test as abnormal, and consider body proportions. And this is even more true if you've got some skeletal problems. You've heard about the girl with neuromuscular disease. And actually, this is a similar case, same measurement in the same patient using two different heights as reference. Here you've got a technically acceptable forced expiratory flow volume curve, and your forced vital capacity is calculated as, or the predicted value is here 2.4. Is it measured or predicted? I don't actually know. It's calculated as 70%. And if you use a different reference, it is calculated as 50%. So this is clearly abnormal. This is mildly abnormal. What is correct? This was a girl with a severe thorax kyphosis. And here standing height was taken, which underestimates true height because of the kyphosis. And here the arm span is taken instead of standing height, which more accurately reflects the body length. And here again, there's reference to Da Vinci. So if you can't measure a correct standing height, then you take the arm span as a substitute. And I've seen one question in the chat, why don't we use arm span all the time? Now, because arm span is always a sum of several measurements, and there is potentially very much variability with all the lines you are following here, it's much less accurate than a good standing height. So for routine purposes, you should always use standing height with a calibrated stadiometer. Okay, so these were our cases. And it's a bit irritating that I don't see the audience, but I think I would like to directly go into the MCQs now. Okay. So now it's your turn again. Which statement regarding spirometry is correct? There is one single correct answer. A normal flow volume curve excludes asthma. B, in obstructive disorders, forced vital capacity, FVC, is decreased. C, inspection of the shape of the flow volume curve is important. D, total lung capacity may be measured with spirometry. And E, FEV1 is more variable than FEF75. So this is mostly related to spirometry. And you can choose now. And here we have the results, and that's actually the key, one of the key messages well taken. You always inspect the flow volume curve first before you look at the numbers, decide whether it's technically correct. And we have heard that most children with asthma have actually normal lung function values, so this is clearly wrong. Obstructive disorder, it's the FEV1, the forced expiratory volumes, and perhaps the flows that are more important than forced vital capacity. TLC is a capacity, which is a combination of plethysmographic and spirometric measurements, and FEV1 is a volume which is less variable than the flows, which by definition are much more variable. Okay. So this, I think, was a rather easy question. Then the next one was a bit difficult during the last slot of the workshop. Which value cannot be read from the flow volume curve? And before you answer that, I would like you to think, what is the flow volume curve? It is the curve with the flow volume axis on the x-axis, flow on the y-axis. Then you see the inspiration and forced expiration with peak flow, etc. And what can you read? What can you not read from this flow volume curve? Is it the FEV1? Is it MEF50? Is it peak expiratory flow? Is it vital capacity, forced vital capacity, or is it FEF25? You can choose now. Think of the curve. And can we have a look at the results, please? Yes, so the majority got it right. FEV1 is the volume which can be read off the volume time curve, which just looks like this, where you have the time plotted on the x-axis and the volume on the y-axis, and everything else can be read off this curve. Okay, next question. Now we move on to body plethysmography. Which statement regarding plethysmography is correct? 1, total lung capacity can be measured with a single maneuver. 2, total lung capacity is measured using a combination of spirometry and body plethysmography. 3, residual volume can be measured with a single maneuver. 4, functional residual capacity, FRC, is the combination of vital capacity and residual volume. And 5, vital capacity is measured using body plethysmography. That is your choice now. TLC is measured using a combination of spirometry and body plethysmography. Yes, very good. First of all, capacity means it's a combination of different parameters, and also body plethysmography measures the volume within the thorax at resting lung volume, and then you do the spirometric maneuver, and this is added on top. This is, of course, the choice number 4 then is wrong. Vital capacity is measured using spirometry, and it's not a single maneuver, but a combination. So all well taken, very good. And now the very last question, again, moving on to another technique, multiple breath washout. Which statement is not correct? MBW allows assessment of functional residual capacity, FRC. 2, MBW usually gives higher values of FRC than body plethysmography. 3, MBW is a tidal breathing test. 4, the lung clearance index, LCI, is calculated as cumulative expiratory volume, CEV, divided by FRC. And 5, the LCI is sensitive to changes in small airways. So one of these statements is not correct. Which one? Okay, perfect. Usually gives lower values of FRC than body plethysmography because it only measures the volume of gas communicating, whereas body plethysmography measures the entire intrathoracic gas volume, which is even in healthy subjects a little bit bigger than the communicating gas. So thank you very much. We can now move on to your questions.
So I just take over because I had a little bit more time than Monica now to read the questions. Oh, yes, you hear me, I think, yes. So one of the question was again about the neuromuscular, the arm span that you use. And one of the question is it really the arm span or the radio ulnar measurements that you would take? So I guess the person is referring to the distance from here to here. Mm-hmm. I do not know this as a normal value that you can use, and I don't know how you could put this in your body plethysmogram as a value, as a substitute. So I would recommend that if you do it, you really take the whole arm span, and it's really a substitute in these cases that you would use. It's no correction factor or so. It's what you would use as a substitute. But as Monica said before and answered already in the chat, it's of course less accurate than the height if you have a child that really can't stand up. So in normal children that can't stand, you will certainly always take the height, and only in these children who cannot stand or who have deformity of the limbs or maybe a huge scoliosis or a very small thorax or whatever, then you couldn't use the arm span. One question for Monica. In CF or PCD patients, when you do a bronchodilator test, sometimes you see improvement after the test, and sometimes this is because they brought up some mucus and cleared the airways. How can you tell whether the post-bronchodilator response is not real and is due to airway clearance?
Well, there are several answers to this question. First of all, a bronchodilator response can be seen in many diseases, and it's not just something you see in asthma. It's less it's less of a less frequent in cystic fibrosis of primary ciliary dyskinesia, but it can be seen. The other thing is in both CF and PCD, spirometric measurements are much more variable than in healthy subjects, and in also much more variable than in asthma, and that probably is also because of the mucus and variable amount of mucus within the airways. But and it really depends, there is no consistent effect of physiotherapy and airway clearance. Sometimes you may even see worsening of lung function following physiotherapy. Sometimes you see no change. Sometimes you see an improvement. What is more typical of secretions in the large airways, if you see some artifacts in the forced expiratory flow volume curve during spirometry, and then you really should ask the patient to do some airway clearance, do some coughing, clear the airways, and then repeat, and then you have a forced expiratory flow volume curve without these artifacts.
One question that I take is one from Dr. Rane. How do we assess true low expiratory reserve volume or false low expiratory reserve volume? By comparing with other values? Well, it's a difficult question. I think it's all, you need to consider all the tests, all the numbers that you see, and then to make your judgment. So it can be, of course, that the patient has just not done the expiratory reserve maneuver, so the expiration completely, because it was done at the wrong time, or the technician did not advise the patient to do it correctly, or the patient was just lazy. And then you have the feeling that the patient has an increased residual volume, but it was just technically an issue. The same is for the vital capacity. Sometimes you can have inspiratory vital capacity that is just not done correctly. And then here you could, for instance, compare the forced vital capacity. And you should basically have two similar values. But this specific question, just looking at the ERV alone, you cannot say. You need to see the whole context, all other values to decide if it's a technical issue or not. And that's why it is important, in my opinion, really to know how your body works. If you have a setting that first the patient does a complete inspiration and then the whole expiration, or if the patient first does the expiration and then the inspiration, and then you can think about what the patient has done and maybe where he has not done it correctly and why your capacities then are not calculated correctly. Good.
There is this question about the expiratory reserve volume and calculation of residual volume. I think, Amy, can we go back to the slides? Because, yeah, I think it's better to explain when we have the...
Case 5, right?
Case 5, yes.
Yes, and there's also another question on case 5. It's good to see it. Someone asked and said the graph of the spirometer does not look very reliable and acceptable. I think it's a good, interesting question. This case 5.
Case 5. This is the young boy. Okay. Actually, this is another example. I think you have to look careful at the breathing maneuver. Have to ask your technician or watch it yourself whether the children were able to do the total or the vital capacity maneuver following the body plethysmography. What you see here is an expiratory reserve volume, which is lower than expected, whereas all the other values, static lung volume, FRC, total lung capacity, and vital capacity here during spirometry are even supranormal, higher than expected. And this is for me an indication that there is some technical problem, cooperation problem in this patient. And then you have to be careful not to judge residual volume, because this is calculated from FRC minus ERV, and then you end up with a false high residual volume and suspect trapped gas in this boy, where I don't think there is trapped gas. And actually, if we go back to it's here in this case. Yeah, I had tried to explain this here where it's even more obvious. with a very low expiratory reserve volume. So after the plethysmographic maneuver, no full expiration, but let's say stop here. Then if you only subtract this little volume from the FRC measurement, then you end up with the false high residual volume and suspect trapped gas. This is something you have to look out for. I find this is very common, although I try to train my technicians very well with these maneuvers, but I see this quite often, and only after exercise, when the children are more relaxed, then they do a better maneuver and have a better, a more valid measure of calculated residual volume. Something to look out for.
Monica, can you just comment on the flow volume curve on the case 5, which was said that it's too, it's not good or acceptable because, of course, you don't have the peak flow, but you have the child has not done a perfect peak flow, but still an acceptable curve, I guess.
I think, actually, in my opinion, this is, at least for clinical purposes, it's an acceptable curve. There is a rise to here on the red curve. You can distinguish a peak flow. I agree. Here you may not, but still it's a reproducible curve. So, and it's a normal peak flow. I would accept that actually. It's yeah. For study purposes, for reference values, you might argue, but I can see the point. So it's a bit flat here.
It was considered that the increase is maybe not so sharp here to get the big flow. The child has not done really the quick manner, but more. Okay.
Look critically, and if you do clinical lung function for clinical purposes, but this wasn't the message. I think the message really was completely normal values in spirometry, and then evidence of something happening in the airways only for multiple breath washout.
Good. One question that I can't answer is about the, we haven't talked about it for neuromuscular patients, the maximal inspiratory pressure that you can use or sniff, which normative values we use. And actually, I don't know which normal value we have in our system, which paper they're taken from. Do you have an idea, Monica?
No, because I don't see many neuromuscular patients, but there are some good publications on that, and maybe we should include that bit
yes.
of testing next year.
If you can write me an email if you want, and I can look this for you. I think, I don't know which paper exactly, which normative values they are taken. Good. And one question was also, I think it's an important one. Should we consider the best amongst, there was written also SVC, which I don't know what is meant here, but FVC or IVC in children. So do you take the inspiratory vital capacity or do you take the forced vital capacity? So I think for the neuromuscular patients, mostly the value that is considered on the long term when you want to evaluate the decline of lung function over time will be the FVC. And these patients, the FVCs may be sometimes a little bit higher. In obstructive patients, the FVC can be lower than the inspiratory vital capacity because you have the collapse of the airways during the expiration. You know, you can just take the best one that you have. And if you follow a child longitudinally, I would always take the same. What's your opinion, Monica, on this?
Sorry, I've missed that. I just wrote.
Okay.
What do you want to know?
If you use the FVC or the IVC to monitor your children on the long term, and I said, I think in the most of the papers, it's the FVC that you see. It's also the one we monitor when we have like the graph that we always look at. We have the trend of the FVC over time. But if you want to see if a child is restrictive, you can also look at the IVC and take kind of the best of your values.
But the FVC is much easier for the children to perform than voluntary, slow, deep vital capacity.
Absolutely. But sometimes they do one better than the other. And sometimes with forced expiration, you have some collapse of the airways, but I can't really answer this perfectly. So that answered the last question. Is there a role of plethysmography in neuromuscular disease children? Yes. Yes, I think we always do follow our children with body plethysmography because we have both values. We have the the IVC and the FVC, and we can see if both maneuvers have been done correctly. But some children, they cannot then go into the body box because they're in the wheelchair, and so you can just use spirometry, and basically there you can use the FVC to monitor a patient, and you can be happy just with the spirometry to follow them. Okay, I think we are just on time. It's 10 to 6. I think it's been a long day for everyone. I thank the audience, these 61 people who have been so brave to listen to us until the end, for their perseverance, for their braveness. And I'm looking forward to see you tomorrow. Oh no, I don't see you, but to see that there are some people listening to us tomorrow morning. I think it starts at 9. So have a very nice evening, everyone. Thank you, Monica. It was like every time a pleasure to talk with you. And well, thank you for the attendance to everyone. Thank you, Amy, for organizing everything, for monitoring. It's super. It works well. Thank you.
And don't forget to give some feedback if